Good afternoon, everyone, and welcome to the Lynn Cancer Institute. We are presenting from our physician panel series today, and today's topic will be a multidisciplinary approach to skin cancer care. We will be learning from our amazing speakers, Dr. Ann Reed, dermatologist at the Rendon Center in Boca Raton, Dr. Harold Huss, surgical oncologist from the Lynn Cancer Institute, and Dr. Anurag Agarwal, radiation oncologist at the Lynn Cancer Institute. We're very fortunate to have these physicians who work with our skin cancer patients. They are experts who are deeply committed to improving the lives of the patients in our community. At the Lynn Cancer Institute, we believe that education and awareness, prevention, screening and early detection, a variety of treatment options, our latest technology, the expertise of our staff, and as we're seeing today, the benefit of our multimodality method of treatment. All combined, we believe, will truly help to save lives. In the interest of time, our bio speakers have been sent to you by email. We invite you during their presentation to please take notes, and if you have questions or comments, please put them in the Q&A box or the chat box, and the doctors will be able to address those at the end of their presentation. That being said, thank you again for joining us, and I'd like to introduce our first speaker, Dr. Ann Reed.
Hello, everyone. I'm Dr. Ann Reed. I want to thank you, Janet, and everyone at the Lynn Cancer Center for having me and for this wonderful annual skin cancer lecture that we give. It's definitely multidisciplinary, starting from the skin check, which we'll get into and what to look for, leading to, radiation oncology or surgical oncology in terms of how do we deal with these skin cancers. So again, thank you for having me. And quick tip, did you know that your skin is your body's largest organ? So there are many different types of skin cancers. The most common type of cancer is basal cell carcinoma. Squamous cell is the second most common, and then melanoma we will see in our patients as well. And that's, of course, a very deadly subtype if it's not caught early. There are other types of skin cancers that you can see here listed. Famously, Jimmy Buffett was known for unfortunately passing away from Merkel cell carcinoma, but there are other subtypes of skin cancers that we see diagnose and treat. So basal cell, again, is the most common type of skin cancer, typically affects sun-exposed areas, but it can be found anywhere on the body, mostly head, neck, and arms. You'll see a shiny pink, pearly papule. So on the right-hand side, the upper photo that you see there is a pretty typical basal cell, what you would see on the skin. Oftentimes people think it's a pimple that just isn't healing or bleeding. And so you'll notice that pretty easily. The flat ones or the superficial types can just look like a pink patch of skin, like you see at the bottom there. So anytime you're going to see something like this, definitely come in and have your dermatologist or have us here at the Rendon Center take a peek. When we catch them early, the cure rate is quite high. And if they are not caught or not treated, they can cause disfigurement. So these are just some examples of patients in my clinic that have had various basal cells and showing how different they can look. So one lesion on the foot there was a non-healing wound in this patient that we biopsied and proved that it was a skin cancer. In the second one here, this is actually a dermoscopic photo of this one on the second column. This is a superficial basal cell. And then here, these are more in a darker skin type. You'll see more of like a purple color, but both of those are basal cells as well. Moving on to squamous cell carcinoma, it is, as I mentioned, the second most common type of skin cancer. Also found in mostly sun-exposed areas, neck, face, the rim of the ears, as you can see in this photo here, arms, chest, and back, and they can grow deep. So these are ones that can actually penetrate bone, and they can become quite aggressive. And so we do want to make sure that we're diagnosing them early and treating them early to prevent them from growing deep or spreading to areas of the body that we obviously don't want them to be. These are more examples. Squamous cell carcinoma on the left-hand side, just a little pink bump that turned out to be a squamous cell. The middle is a photo of me just removing one with a standard excision in the office. And then on the right-hand side, a pink patch that can look very much like the basal cell photo that I showed you. So oftentimes these are differentiated by microscopic, by pathology, dermatopathology. Moving on to melanoma, this is the deadliest form of skin cancer. The reason is because it does have a tendency to spread and metastasize. If it is, typically it's a dark spot, but it can also be a pink spot. It can be pretty much any color. And it has what's called the ugly duckling sign. So what that means is, most of our moles will look a certain way, and then there's just this one that catches your eye. And so if you see something called the ugly duckling sign, definitely come in and, show us, let us know, that you've noticed a change in your mole. And it can be a de novo, which means it can start out from nothing, or it can be a mole that you've already had that changes into an atypical or a melanoma. So this is where we get into the ABCDEs of melanoma, and I will review those with you. But first, I'm going to show you just some more photos. The top row is the macro. So this is what you'll see with your eye. And then the bottom row is my dermatoscope. So this is what I see and kind of what helps me decide whether something requires a biopsy or not. Now, on the left-hand side, that's obviously a good ugly duckling sign there. You can see that the person's other moles are light brown, small, and then right in the middle is this thing that really stands out. So this is for sure going to be biopsied. On the middle photo, that one is just like a little brown rim. But it looked a little atypical on dermoscopy, and so that was a surprising melanoma, but it was an early melanoma. And then on the right-hand side, this was a birthmark the patient said he had for over 10 years. I'm sorry, that it hasn't changed for over 10 years. He's had it since birth. And to me, there was, multicolors. If you look at the bottom right circle, you can see pink, you can see white, you can see dark brown, you can see light brown. So this, did get biopsied and turned out to be a superficial spreading melanoma. There are variations. You can get nail melanoma. Not every brown line on your nail is melanoma, so come get them, checked out if you do have a brown line. This is obviously, on the left-hand side, if you see these little ticks, the little black lines, these are 1 millimeter. So this is obviously going to be, 4 or 5 millimeters. And so that's something that we're going to want to biopsy as dermatologists if you see it that thick and affecting the cuticle here. In the middle, this is an amelanotic melanoma. So to me and to anyone that just saw pictures of basal cell and squamous cell, you might think that that's what this is. And so really just knowing through pathology or the future techniques with AI and other things that we're, seeing come out on the market may help us guide our diagnosis. Ocular melanoma is not something we can see. It does need to be, you need to use special sort of tools to see that. So your eye doctor would be the one to find that. Merkel cell, just because we heard a lot about Jimmy Buffett, so I'm going to very quickly just briefly review it. It is very rare. It's an aggressive cancer. Typically starts out like a pink bump on the head and neck of an elderly person. 80% of them are associated with a virus called the Merkel cell polyoma virus, and 20% are caused by UV radiation. Typically, when we find these, they're quite advanced, and they can advance rapidly. But there is, and maybe Dr. Huss will review, or that there are immunotherapy medications that can improve survival rates, but this typically is a poor prognosis, unfortunately. So let's get into our ABCDs. What does it stand for? So A stands for asymmetry. On the left-hand side, you'll see a column of benign nevi or benign moles. And on the right-hand side is malignant melanoma. So asymmetry on the left, obviously if you cut it in half or you cut it in quarters, it pretty much is symmetric. On the right-hand side is not symmetric at all. I don't think any of those photos would show symmetry on the right column. B is for border, so uneven border. So not a very, sharp border. You're going to have either a cloudy border or just a very uneven border. C stands for color. So if there are two or more colors, it's okay to have two colors. Sometimes three colors are okay, but typically if we see this many colors, it's going to prompt us to do a biopsy. D stands for diameter, and we typically say if it's bigger than a pencil eraser, about 6 millimeters, that you're going to want to have it checked out. And E stands for evolution. So this is what you tell me as a patient. Hey, doc, this was one way, and now all of a sudden it's changing. Size, shape, color, you just have a bad gut feeling about it. That means a lot to a dermatologist because you know your skin better than anyone. So these are things you can do at home. Look at your moles and see whether they meet criteria for A, B, C, D, E. And if you find that anything looks suspicious, schedule a skin check with your dermatologist. So that's me. How do we screen and diagnose skin cancers? There's a dermatoscope in my hand that helps me see the skin at a little bit of a higher magnification with polarized and non-polarized light. We can perform a biopsy. You'll see here different variations, a shave, a punch, or an excisional or incisional biopsy. There is confocal microscopy, which is the machine you see on the top right, that can see under the skin without invasive biopsies. There is genomic testing that really has helped us differentiate benign versus malignant lesions. And then now with newer advanced technology, there's devices powered by AI, such as the Nevisense or other, mole mapping. I do think that the future is really, really bright. And I feel like, I know it's not a lecture about AI, but I do think that AI can help improve our ability to diagnose, and we can work with it in order to have better outcomes with our patients. So how do we prevent? Because a lot of these are sun-induced and on areas of sun exposure. Most of the skin cancers and deaths are caused by UV radiation. So we want to avoid the sun at peak hours. So 9 to 4. In Florida, 4 is still kind of early. We can get sun till 7:30, and we don't want to be laying out there, but between 9 and 4 specifically, if you have early morning sun, it's much better for you versus mid-morning and no more than 15 minutes of unprotected sun exposure. So we do want to use broad spectrum sunscreen with an SPF of at least 30 on your unprotected skin, as well as sun protective clothing. For example, like a rash guard, like you see my son Mason on the left-hand side at the beach. He's got his rash guard, he's got his hat on. We put sunscreen all over any exposed areas, and after swimming, you want to reapply. Children and adolescents, speaking of, they do need to be protected from excessive sun exposure because they have a much higher risk of melanoma if they have severe sunburns early in life. And I like this little cartoon here that with a tanning bed that says select a cancer, because that's pretty much what you're getting from those. I love this photo because I do feel like it really shows a beautiful way to prove how UV rays affect your skin. This is from the New England Journal of Medicine. This is a truck driver who spent over 30 years driving trucks. And on the left-hand side in America, that's the side that we get sun on. And you can see how obviously aged and different the left side, his left, your right, versus the right side. So, when you tan, your skin is actually getting damaged. And as this damage increases, your skin not only ages, but it also increases your risk of skin cancer, including melanoma. So this is how I go to the beach or on a boat. I do wear long sleeve bathing suit that helps protect, and obviously everything else is protected with sun protection. There are wonderful natural things you can do as well. Nicotinamide is vitamin B3. You can find it in chicken and fish and eggs and nuts. This has been proven to reduce actinic keratoses and squamous cell carcinomas in a large study. And so I think that it's wonderful. And I personally supplement with nicotinamide. Also, polyphenols are found in vegetables and fruits. So if on the right hand side there in that box, you can see foods that are rich in polyphenols. Anything that's orange or red can be like an oral sunscreen. It doesn't replace actual sunscreen, but it can definitely help. I see dark chocolate there, which is always a great thing to protect your skin with. The antioxidants are wonderful. And then lastly is Polypodium leucotomus, which is a mouthful. It is a fern from Brazil that they have extracted and put into a supplement. There are various brands of the supplement. One of them is called HelioCare, and this is an oral skin protectant. So what they found in the studies is that if a patient took it and they irradiated the skin with UV light, they were less likely to burn when they took Polypodium leucotomus. So I personally take it if I go on cruises, if I'm going to the beach with my kids, just as a nice protectant, or let's say I'm playing tennis or I'm going to be outdoors at my son's baseball game. I'm definitely going to be, protecting myself and making sure that I think of all these ways for skin cancer prevention. Thank you so much for having me. That's the end of my talk. I'm looking forward to everyone else's, and I'll be here at the end if anyone has any questions.
Thank you so much, Dr. Reed. Dr. Huss?
Hello, everyone, and thank you for coming today for this excellent lectures that Jan prepared for all of us. Today, I'll be speaking about surgery for melanoma and other skin cancers. Skin cancer is the most common cancer in the United States. 1 in 5 Americans will develop skin cancer in their lifetime. Almost 10,000 people in the United States every day are diagnosed with skin cancer, and that equates to over 6 million cases of non-melanoma skin cancer, which is treated in the United States every year. Of course, there's a lot of overlap between dermatologists and surgeons, and you'll see some overlap between myself and Dr. Reed. The most common skin cancer, basal cell carcinoma, and of course the surgeons get the larger basal cell carcinomas, and the dermatologists usually treat the smaller ones. Basal cell carcinoma, you could see, could be basically on any skin surface, small and large. Basal cell carcinoma does have a chance to spread, albeit small, but they definitely do have a chance to spread. Talking about spreading, squamous cell carcinoma definitely has a chance to spread, greater than 10% chance. And as you can see, if not treated, and a lot of these are neglected, these squamous cell carcinomas could grow very large and rapidly, and certainly can spread and cause a lot of issues, as you can see, bleeding one of the issues. Melanoma, a very aggressive skin cancer that we'll talk about a little more later. Once again, on a lot of different skin surfaces, even skin surfaces that you think that how does sun reach, the bottom of the foot. Merkel cell carcinoma, very aggressive as well, but much rarer, as opposed to 10,000 cases of melanoma in Florida every year. Merkel cell is about 1,000. Then you have adnexal tumors. These are rare tumors as well, tumors such as porocarcinoma, sebasteoma, hidradenocarcinoma, and many others that are rare, but also that we need to be concerned about. These are a few pictures of metastatic disease. So cancers that spread to the skin. The top right corner, metastatic breast cancer. The bottom left corner, metastatic colon cancer. And the one in the middle is from an unknown primary. That means we don't know where it came from. There are also cutaneous sarcomas, sarcomas in the skin, like Kaposi sarcoma, angiosarcoma, cutaneous leiomyosarcoma, and many others. There are also cutaneous lymphomas. That would be B-cell and T-cell lymphomas like Sézary syndrome and mycosis fungoides, also to be aware of. So the treatment options for most of these are surgery, a Mohs procedure, which is a procedure that dermatologists perform, which is much less invasive than surgery. Systemic treatment like chemotherapy, immunotherapy, radiation, topical treatments, and local treatments, or a combination of these. But today we'll focus on melanoma. So as you can see over here, melanoma can be on any surface, whether it's the mouth, the eyes, the nails, the intestines, the foot. It is one of the most serious forms of skin cancer. Over 100,000 people in the United States were diagnosed in 2025, and almost 10,000 deaths. And in Florida, we have over 10,000 cases, which is second to California, but per capita is the number one. It has the most melanomas in the country. It is the fifth most common cancer in men and women. However, in 2040, according to the experts, melanoma cases will double and it will become the most common cancer in males. You see it most commonly on the back in men and the legs in women. It is more common in men. Once again, you could see it on many different surfaces. Only 25 to 30% of melanoma come from moles. The incidence increases with age, and that's why one of the reasons why we see so much melanoma in Florida, because of the age population in Florida. And most melanomas are found by patients themselves. The highest rate of melanoma in the world is seen in Australia and New Zealand, of course, because of sun. Sun exposure causes most of the melanomas. Survival depends on stage, so early diagnosis is crucial. And if you see something, go to your dermatologist immediately, because survival really depends on localized disease, where the cure rate is very high, as opposed to if the disease spreads to the lymph nodes or other organs. So what is melanoma? So melanoma is a type of cancer that comes from melanocytes. These are cells, these are pigment producing cells that produce melanin, which gives the skin the brown color, and also protects the deeper layers of the skin from sunlight. Most melanomas are confined to the epidermis, the top of the skin, and if they grow radially on the top of the skin, it is pretty curable. However, once it starts growing vertically, like a nodular melanoma, then you have to worry about metastasis. There are many types of melanomas, but the four most common melanomas are superficial spreading. Most melanomas are superficial spreading, greater than 70%. Most of them are thin, less than 1 millimeter. Most of them come from a pre-existing nevus, and they can occur from anywhere on the body. Nodular melanoma, which is very worrisome, only 15% of melanomas. These are usually ulcerated, and these are usually thicker than 2 millimeters. Then lentigo malignum melanoma, only 10 to 15% of all melanomas. These usually we see on the elderly people, and they're slow growing. And acrolentiginous melanoma, these are less than 5% of all melanomas, which we usually see on the palms, soles, and nails. So risk factors for melanoma, of course, we know about sun and tanning beds, family history of melanoma, personal history, whether you have a history of skin cancer. Anyone who has a history of skin cancer has a risk for other skin cancers. Many moles, a history of severe sunburn in their younger years, fair skin, light eye color, and patients that are immunocompromised. As Dr. Reed explained, we can biopsy, we can make a diagnosis with many different types of biopsies, shave, punch, excisional, and incisional, and they all have their benefits and risks. We already discussed the ABCDEs of melanoma, which if you take away anything from all the lectures today, that's probably the most important thing. You should know the ABCDEs, and then proceed to your dermatologist if you think that you see any of these. Screening, there are many ways to screen. Of course, by yourself, screen yourself, look at yourself in the shower, and of course, make sure you go to your dermatologist at least annually, if not more. And now we have a whole bunch of different small and large cameras that can help with screening as well. So the treatment for melanoma, there's surgery, there's immunotherapy, which has certainly changed the paradigm of melanoma in the past few years, and really changed the survival for the benefit of patients who have melanoma. There are checkpoint inhibitors and targeted therapies, and of course radiation. So if you have a stage 1 or 2 melanoma, the standard of care is a wide local excision. Depending on how thick the melanoma is, we perform either a 1 centimeter or a 2 centimeter margin. Once again, an early stage prognosis is very good. And here are just a few photos of early stage melanomas. The top line, you see a melanoma on the leg, and then the second picture is where it's removed. And then we perform a skin flap where we remove tissue, move tissue from around the area, and then it comes out, as you can see in the last picture. The second row, sometimes when you have melanoma specifically on the leg, especially in the pretibial area, there's not a lot of skin to move around. So therefore you need a skin graft where you take a piece of skin from another area on the body, for instance, the thigh, and then you just suture it to that area. So the second line is a skin graft. The third line is another skin flap. This is a melanoma on the scalp, where you can see that we move tissue around on the scalp to cover the defect. These are another few pictures of melanomas on the chest wall. And of course, cosmetically, we want the nipples to be stay where they are. So therefore, we have to design flaps to cover the defect, but also keep the nipples in place and symmetrical. Here are another few pictures. The top line is on the arm, and that's a different type of skin flap. And the last line actually is a melanoma on the foot that was removed, and it actually just closed by itself because the patient, due to poor compliance, the patient did not come back to see the plastic surgeon. Sentinel lymph node biopsy, something which is very, very important in melanoma. Sentinel lymph node biopsy is the first lymph node that a melanoma would spread to if it did spread. So as we said, that melanoma is a very aggressive skin cancer, and it could spread, has the potential to spread to almost any organ in the body, but the most common place that it spreads to are the lymph nodes. So we want to know if it spread to the lymph nodes, could we possibly find the first lymph node that it would spread to and remove that lymph node and send it for pathology? And that will really help us with prognosis and treatment. So we have a procedure called lymphoscintigraphy, which patients go to before their melanoma surgery. They go down to nuclear medicine, where nuclear medicine injects a radiotracer near their melanoma, and they follow the radiotracer, goes through the lymphatic system, and then it goes to a lymph node, and then the machine takes a picture, and in the operating room we have a fancy pen called a gamma probe where we can detect the radiotracer, and then we remove this 1 or 2 sentinel lymph nodes, and then we get our results. So when do you do a sentinel lymph node biopsy on a patient? Well, the patient has to have clinically negative nodes. It means you can't palpate a node, because if you palpate a node, then you need a biopsy before surgery. You perform a sentinel lymph node biopsy on patients that have intermediate or high risk for lymph node metastasis, and that means greater than 0.8 millimeters, so 0.8 of a millimeter, so smaller than a millimeter thick, or less than 0.8 of a millimeter. However, it has an aggressive feature such as ulceration, high mitotic rate, or lymphovascular invasion. If you have a positive sentinel lymph node, in the olden days, we would then remove all of your lymph nodes in that basin. But due to multiple trials, we found out that greater than 70% of the time that we remove the additional lymph nodes, which has significant side effects and complications, most patients do not have any other lymph nodes that are positive. So therefore, there are a lot of patients that we just surveil or follow very closely. So for stage 1 and 2A, which are low risk melanoma, surgery alone. Stage 2B and 2C, these are high-risk melanomas, and not only do we perform surgery, but also a year of adjuvant immunotherapy. And stage 2B and 2C are melanomas that either are greater than 2 millimeters and have a high-risk feature, or greater than 4 millimeters, even without a high-risk feature. Stage 3A is a low-risk node-positive melanoma, and for this stage, we either surveil or give immunotherapy. However, for stage 3B, 3C, and 3D, these are all stages that the lymph node is positive. So for macroscopic disease, that means we can feel a lymph node, and we biopsy it and it's positive. Then we give immunotherapy, followed by surgery, followed by immunotherapy. And for microscopic disease, meaning that we perform a sentinel lymph node biopsy and it is positive, then we give a year of adjuvant or after surgery immunotherapy. Metastatic disease that spread to another organ. Usually it's systemic treatment like immunotherapy or targeted therapy. However, sometimes we need to operate for reasons like bleeding or obstruction of bowel. How about recurrent disease? Recurrent disease, so you operate on somebody's melanoma and then it comes back. So local recurrence, so it could come back one spot, or you can have 10, 100, or 1,000 spots. So if it's within 2 centimeters of the primary lesion, it's called satellite disease, and greater than 2 centimeters, it's called in-transit disease. And if you just have 1 or 2 spots, you could operate and you could remove it and also consider immunotherapy. However, if you have so many spots, you can't just remove 10 or 100 or 1,000 spots. It's too much. And therefore, we have other treatments like TVEC, ILP, and ILI, which are either hyperthermic isolated limb perfusion or hyperthermic isolated limb infusion. One is an open procedure and one is a percutaneous procedure, where you find the affected limb, let's say the leg, and you tie it off and you give chemotherapy directly into the affected limb. And TVEC therapy is a herpes virus that we inject into the melanoma, and it not only kills the melanoma, but it also affects the immune system to attack the melanoma further as well. And these are all these treatments are FDA approved. Prevention, as Dr. Reed mentioned, self-exams, sunscreen, avoid UV nail lamps and tanning beds, sun protected clothing, and of course, going to your dermatologist. So, is melanoma a cancer? Many times a week, I have patients that ask me, is melanoma a cancer? Meaning, do I have cancer? As you can see from this picture, you could see melanoma in the brain, you could see melanoma all over the skin, and you can see the PET scan on the right or the bone scan in the right top corner where it's involving everything. And some of these CT scans, these are melanoma involving the stomach, the esophagus, the intestine, the rectum. So melanoma is a cancer that can involve anything and everything. So in conclusion, melanoma is a cancer that is very aggressive locally and metastatic. If you are concerned about a mole, any of the ABCDEs, see your dermatologist. Stay out of the sun and protect yourself with appropriate clothing and sunscreen. Surgery is still the standard of care for melanoma and the majority of skin cancers. And there have been multiple new treatments for melanoma, especially immunotherapy and radiation options. And once again, I'll be happy to take questions at the end.
Thank you, Dr. Huss. Dr. Agarwal?
Thanks for inviting me. I see Sandy and Anna are dialed in. I hope you don't get disappointed. There's no Beyonce music videos in this lecture, but we're going to have fun. We had two great presentations by surgeonc and dermatology, so I'll skip through some of the slides because they'll be redundant, but I think this is important. Let's get an idea of the scale of the disease in terms of what we're talking about. Even uncommon diseases, sometimes, they deserve a lot of attention, obviously, because, every patient is important, every life counts. But I think in terms of skin cancer, it's such an overwhelming problem. So literally, there's over 5 million cases diagnosed just in the US every year. And when we're talking about these skin cancers with keratinocytic carcinomas, these are basal cell and squamous cells. So this is most of what we do in radiation oncology as BCCs and SCCs. The surgeons, the dermatologists, and the medical oncologists usually are more involved with the melanomas, and they're much less common and they're much more aggressive potentially. So 5 million cases of BCCs and SCCs per year in the US. It's the most common cancer. If you were to break it up from a radiation perspective, 75% of the skin cancers we see are usually basal cells, less than 25% are squamous cells. So BCCs outnumber SCCs at least 3 to 1, 4 to 1. This is, I think, an important slide because look, what are we talking about today? We're talking about skin cancers and we're talking about basal cells, squamous cells, and melanomas. But look at all of these. This is what we work with in terms of radiation oncology as well: breast cancer, prostate, lung, colorectal. And so there's so many different types of cancers out there. But look at this pie chart, 48 and then another 24. So we're talking about almost 75% of cancers that are diagnosed in the US every year are just basal cells and squamous cells. So it's an astounding number. It's a crazy high percentage of patients that get affected with these two diseases. And all of the other cancers are kind of, in this pie chart, you can see like less than probably a third or so of the cancers. So we talked about this already from the other expert speakers, but basically we want to counsel our patients to minimize UV light exposure. Just be practical. You don't have to, live inside, but when you go outside, you enjoy the Florida sports and the sun. Protect yourself, especially at an early age. Very important for kids and pediatrics. What are other risk factors as we get older? Skin cancer is more common uh, as you get exposed to certain types of things, like, for instance, tanning booths, a history of other types of skin lesions, AKs, if they're left untreated, actinic keratosis, maybe can over time, over decades, progress to skin cancer. So this is why dermatology, surveillance, and regular follow-ups and screening is very important, because sometimes they're freezing these lesions off and someone might think, oh, it's not a big deal, but over time, any of these things can progress. Patients who have organ transplant history, they're usually on immunosuppressive medications, and they can also have an increased risk of skin cancers. So we've all had patients who are have had organ transplants, and then they just have multiple skin cancers pop up like every year, like clockwork. That's obviously a big risk factor. So in South Florida, California, a lot of areas, this is crazy, right? Patients are paying to go sit in sun tanning booths. And they're doing this for aesthetic reasons, because they think that their skin looks better. But I thought that was a wonderful picture that was just presented earlier today about that truck driver at the beginning of our conference, where the left side of his face looked so aged compared to the right side. So if we properly counsel patients, I think will help at least some of them. So I don't think most patients that get inside a sun tanning booth realize really what the extent of damage is, especially if they do this on a regular basis. Same thing with long-term sun exposure. I mean, these are very, very real risks. And you saw some of Dr. Huss's pictures that he showed with you, that these are sometimes not just small little pimples that don't have aesthetic impact, that have a very minimal aesthetic impact. Sometimes these squamous cells and basal cells can grow and become very invasive and very disfiguring. All right, I'll skip over the ABCs. We went over that already, but I think this is very important for just, everyone to kind of have in the back of their mind when they see skin changes. Run through this algorithm. It's pretty easy and it's pretty simple, and it works. You've seen some pictures of different types of lesions. We talked about melanomas, basal cells, squamous cells. Remember, these are more common. These are a little less common, and these, thankfully, are the least common in terms of the three that at least I'm focusing on in the talk today. Can you see my slides?
Yes.
Okay.
Yes,
Because I'm having someone's email show up on my screen, but as long as you can see my slides. Okay. Here are some more pictures. The basal cell, squamous cell, melanoma. I'll go through these quickly. Okay, so melanoma mortality. Melanoma is not the same as the basal cells and squamous cells. Most patients with basal cells and squamous cells, most do very well with proper treatment, whether that's Mohs surgery, surgical incision by a surgical oncologist like Dr. Huss, or, or some other type of treatment like the radiation. Melanoma is a different diagnosis. It has a higher mortality. It's more dangerous. It's different. We know that there are disparities, unfortunately, in our country and, pretty much everywhere on the planet. So case by case, stage by stage. If you're Black, the survival data is less than for white patients historically with this disease. This is a relatively small number, 7,000. Remember when we talked about over 5 million cases per year of the SCC, squamous cells and basal cells being diagnosed. So 100,000 melanomas are diagnosed per year in the US, and less than 10,000 of them result in death, but still significant number of patients. These can spread more often to lymph nodes. This is why really you need a multimodality expert team evaluating you. It's not sometimes as simple as just, taking it out or taking a biopsy. Complicated issues come up, whether you sample lymph nodes or not. We discuss this all the time in our cutaneous tumor board. It's great to have someone like Dr. Huss, a surgical oncologist, that's up to date on all the latest literature to be able to advise, does this patient need sentinel lymph node mapping or not, and why, and what are the side effects. So that's a different diagnosis in and of itself. The squamous cells and basal cell patients do typically much better. In the radiation literature, usually I quote to my patients, it's a 99% cure rate, either with Mohs or with external beam radiation for the average small, well-circumscribed squamous cell or basal cell cancer for most patients. Basal cell is considered to be even a little bit better in terms of prognosis than the squamous cells. The times we see problems with the patients with the basal cells are when patients really ignore their disease, or there's psychosocial issues or economic issues, lack of insurance, or other stressors going on in life over a longer period of time. And sometimes we'll see basal cells that are very large and disfiguring. You can use radiation as a primary treatment for especially the basal cells and squamous cells. Especially when surgery is not feasible or contraindicated, or sometimes patients just are averse to surgery. They say, well, I've had a bunch of Mohs surgeries in the past. I've recently been put on a blood thinner. I have a cardiac problem. I've got a pacemaker. I'm having all these other issues. It's in an area of the body that I'm concerned about aesthetically, specifically. And, you weigh in a bunch of different variables. So, pretty much for any basal cell or squamous cell, provided they've had appropriate multidisciplinary evaluation, meaning at least a good conversation with their dermatologist, radiation has a potential role. Melanoma treatment is much more tricky. This, sometimes can just be resected by an expert dermatologist or a surgeon or surgical oncologist. Sometimes we have to involve our medical oncology colleagues for immunotherapy for more advanced cases, sometimes even chemo. When do we not use radiation? Pretty much anyone with the BCC or an SCC is a reasonable radiation candidate, or at least a reasonable candidate to be evaluated by a radiation oncologist. Certain patients who have certain types of very rare syndromes, they have a amplified toxicity to radiation, so we're much more cautious about giving them radiation treatments. So you don't see these very often, but Gorlin syndrome, let's say, autoimmune diseases, scleroderma, lupus, they're more common in women. So if you have, let's say, a lady who comes in with pretty advanced lupus, she's on multiple medications over the years, the lupus is progressing, she's on active immunomodulator therapy, that might not be the best candidate for giving her radiation for something like a basal or a squamous cell. If they've had radiation in that area of the body before, that's something that we have to use caution about. So these are non-melanomas, brachytherapy, external beam radiation therapy. You already saw two beautiful presentations on the surgery aspect of it from a dermatologist and from a surgeon. They use creams sometimes, the dermatologist, photodynamic therapy, cryotherapy, all sorts of things. Really too much to talk about in one talk. In terms of radiation, this is brachytherapy. This is like a little R2D2 machine. It has a radioactive seed inside of it. The radioactive seed comes out through this catheter, and this catheter is connected to the patient's body, delivers radiation for a minute or two. The radiation seed comes back in. It's in this machine. This lady's standing here hooking up the catheter. She's not getting any radiation dose. But when you move away from the machine and you step out of the room, then the machine is programmed for the radiation seed that's in here. It's shielded right now to come out through this catheter into the patient for a few minutes, and it delivers radiation. And it's very superficial. It doesn't penetrate deeply. So it's not like if it's a radiation seed and you put it on the skin, that it's going to exit the body on the other side. It's a very small amount of penetration into the tissue, which is excellent, obviously, for something like a skin cancer. So this is the machine again. These are the catheters that are put into the machine. This is kind of a magnified viewed, so you can see the catheters. You don't have to obviously put in all of these catheters, but it can handle a number of catheters depending on the machine. And then these catheters, remember, there's one radiation seed, and the seed goes through these catheters. It comes through one catheter, it goes back in, it comes out through the other catheter, it goes back in, it comes out through the other catheter. Sometimes you just need one catheter, sometimes a few. This is a Freiberg flap. So this is a patient, his head is over here, these are his feet. He's laying on his right side, so that's his right foot. This is his right leg. This is a flap that's put on, and the radiation seeds will come out through these catheters, stop at these locations at different points for a few seconds, and then deliver a very nice radiation dose cloud to the surface of the skin and just underneath it to the area that's at risk. Here's someone who has a lesion on the skin near the nose, to the right of the nose. So this would be the eyes up here, nose. You can see the lesion here. And this is a few years after the squamous cell was treated with brachytherapy. Brachytherapy is that little R2D2 unit, right, that I just showed you. And you can see the aesthetic outcomes can sometimes be excellent. We can't guarantee that everyone is going to look like this, but you can certainly, in a good number of patients, have great long-term outcomes. And why use brachytherapy? Because remember, the surrounding tissues really receive a minimal dose in brachytherapy. So you have very, very little toxicity when you deliver brachytherapy for skin cancers, because the dose is very, very localized to the target, which is where the skin lesion is. Here's a Leipzig, which is also the catheter would be connected to this, and you can see this it's like a little paperweight almost. It sits on a certain body part, and the seed would sit in here for a few minutes, deliver radiation superficially, and the seed goes back into that little machine. Very easy treatment for a patient. Here's another arm, and you can see these catheters, and basically like where you see all these circular spheres, the radiation seed can stop at these locations, and it stops for X number of seconds in each location. After a few minutes, the treatment's done. The patient gets up, goes home, goes to work, whatever they need to do. Pretty easy treatment. Again, Freiberg flap for the foot. So these catheters are connected to that machine. This is all an example, again, of brachytherapy. Sometimes you'll see the word HDR, high dose rate. So these are all examples of that machine that has the little seed, and it comes out through these little catheters to different parts of the body. So it's a very elegant, precise treatment, especially for surfaces that are curved or that may be irregularly shaped. You can really take this material and cut it out into almost any kind of shape that you need within reason to cover the surface of the skin where the disease is. Here's another example. These are the catheters. This radiation seed could stop at any of these points here, large lesion on the skin. Here's an example on just like a mannequin, but like this could be put onto a patient's face, and you could see here on an axial CT All these little dots are where the catheters are on one cross section of the CT, and they would stop at a certain point, deliver radiation dose. And this gives you a visualization too. This is the nose. Imagine the eyes would be here. And so everywhere you see these little dotted lines is where more or less the radiation seeds could stop. You can actually see the dots here, the red dots. That's where the seed would stop and deliver a radiation dose. So we can really sculpt things very elegantly, very precisely to the target and spare toxicity. Brachytherapy timelines, maybe somebody would come in 8 treatments, maybe like they'd get a treatment on a Monday, another treatment on a Thursday, twice a week. The treatment itself is super quick. It's like 5 minutes. But the setup and getting in place, and we have an expert physicist that's always on site for these type of treatments. This is not, this is not like just a very whimsical treatment that somebody just decides, yeah, I'll just get a little bit of radiation. I mean, there's an incredible amount of planning. There's a lot of expertise. It's simple from a patient experience perspective, but you absolutely need a great team to do this properly. So you have to have a great physics team and great radiation therapists, and then of course the whole team in terms of nursing and doctors to support everything. But for a patient's perspective, it's pretty easy to come in maybe 8 or 10 times. They're laying on a table for 20 or 30 minutes, and the treatment itself is super quick. Here's another way to deliver radiation. This is called a linear accelerator. Only radiation oncologists can do this. And so some cases are not amenable to brachytherapy, and they're better treated with this, which is a linear accelerator. So the radiation beam would come out of here, and we would, again, very, very precisely target the skin for the radiation treatments. This machine here, you can have a device extended on the edge of it, which is this. So this device is connected to this head of the machine where the radiation is coming out. And then the electrons, the very superficial radiation, are delivered to the skin very precisely. Here's a patient before radiation who has multiple lesions on the scalp. And this is after radiation therapy, after he's healed up. You can see how beautiful it looks. This is using a very sophisticated, what's called VMAT arc therapy, using this type of machine here. So this is for more advanced cancers, and you can encompass a very large area, irregularly shaped, sculpt the radiation dose around the skin on the scalp, but minimize the dose that's actually going to enter the brain. And just again, to give you some examples, I have a minute left. Here's how the lesion looks. Here's how the lesion looks after 15 treatments of radiation, and then maybe a month out or so. Sometimes, usually patients recover. It depends on the individual patient how quickly their skin recovers, but you can see the skin very often will just kind of go back to normal. External beam timeline. So external beam, remember, is this machine right here. It's a little different than the brachytherapy machine. So that's maybe 20 treatments. That's one treatment a day, Monday through Friday. Each treatment takes about 5 minutes, but the treatment time in the office might be 20 or 30 minutes in terms of how long a patient's there. Usually our patients feel great. There's no nausea, no vomiting, no hair loss, unless we're specifically targeting the hair on the scalp. The skin gets more red as they progress with the number of treatments. Sometimes they can have desquamation, which is a little bit appealing, but generally they do pretty well. And I think that's just, I wanted to hammer the point of it's important to go to the right type of doctor. So sometimes patients get alternative type of treatments, or, people can just set up shop, and they don't necessarily need to be super qualified. Everyone you've listened to today, from the expert dermatologist to the surgical oncologist, or if you see a radiation oncologist, I mean, there's a lot of years of training that go behind this, at least 4 years of high school, 4 years of college, 4 years of medical school, 1 year of internship, 4 years of radiation oncology residency. This differs a little bit depending on the specialist. We have to sit for written oral examinations. So they have to get board certified. If you do a brachytherapy fellowship, that's an extra year. So it's important, especially in South Florida, you have access to excellent physicians and teams to avail yourself of that. So thank you. Give control back to you, Jan.
Hey, Thank you. As you said, this is such important education, and especially for those of us that live in Florida. And I appreciate that you provide this education for us on an annual basis because there's always so much to learn. We do have a couple of questions. Um, and I don't know if you can see them, but I'll read the first one is why are, oh, excuse me, why are childhood sunburns such a risk? And we could probably hear a comment from each of you unless somebody wants to answer that.
So the reason why childhood sunburns are so bad is because, as we know, sun damages DNA of skin cells, and these damages are cumulative, and they are passed down to cells, and over many years, you can imagine the cells get worse and worse and worse. So it's a cumulative damage. Plus, we know from literature that between the growing years of 10 and 20 or 15 and 20, if you have five sunburns, that your risk of melanoma increases by 80%.
Oh,
So it's a cumulative reaction.
Yeah, I agree with that. It's more it's the very intense, like a bad blistering sunburn, is highly linked to melanoma in the future, and it causes mutations, which when the child is young doesn't necessarily cause any issues, but as Dr. Huss mentioned, it is all cumulative, so it just builds upon itself, and maybe by that time that 8-year-old is 40 or 60, they may start developing more mutations, which can lead to skin cancers.
And the other also, you look at an elephant, you look at a rhinoceros, and you see how thick their skin is. Um, a child has a very thin skin and much more easily damaged by sun rays.
Right.
thank you both. The next question is, do we know of any risks from the red light therapy that is so popular today? I just heard about it last week. So.
I can take this one because I get asked this a lot in the office. So, red light therapy is photobiomodulation. Red light or visible light is non ionizing light. So, the wavelength is going to be longer. UV rays, the ultraviolet rays, are going to have a much shorter wavelength, like between 1 and 400. So those cause this more energy that's able to hit the surface of the skin and can cause damage. Whereas biomodulation with red light or near infrared light is red lights, but like 600 or 700. Near infrared is going to be a little bit more than that. So these are less energy. These actually produce a bit of ATP production in the cell, which can increase energy, can also has been proven to decrease inflammation and aid in wound healing. So in terms of skin cancers, I don't know of any known risks. However, if there is a skin cancer on the skin and you put red light on it, there we don't know what can happen. So definitely don't recommend that at all. And then again, quality matters, and you can't just go on Amazon and buy a red light or just like a red light bulb, because the wavelengths can be poorly controlled depending on the manufacturer. So you want to get a good quality one that is recommended, and make sure that you speak to your physician about it, or that you read reviews and make sure that there's really good data behind it.
Thank you. Interesting. Dr. Agarwal, do you have anything comment about that? Dr. Huss had to leave. He had a surgery. So.
I don't. I think Dr. Reed covered it.
Okay. Thank you so much. And as I said, thank you so much. This education is so valuable, and just like red light therapy, we are learning something new every year. So we appreciate the time and effort that you put into the research and putting together a presentation as comprehensive as you each did. So we
Thank
appreciate
you.
the
Thank
generosity.
you for having us. Appreciate it.
And to our audience, our lectures are all recorded. So if you would like to review this presentation again, or I'm sure we all have people that we'd like to share it with, when Lee sends out the evaluation, we appreciate you completing the evaluation and sending it back to her. But at that time, you can also request a copy of this presentation. It should be ready by Monday of next week. And just one little note, this concludes our presentations for the month of May. And in June, we're going to be offering a presentation from our survivorship series. The title will be Cancer Survivorship Updates, What You Can Control. And the speaker will be Darcy McNally, Director of Support Services and Community Outreach here at the Lynn Cancer Institute. So we hope you all come back for that education. And thank you, Dr. Reed. Thank you, Dr. Agarwal. And when you see Dr. Huss, thank him. Have a
Thank you,
good
Janet.
weekend, everyone. Put your sunscreen on.
That's right.